Or you need a senior reg who's done it before, or a consultant's done it before.
But if they're during an arrest and there's no one else around and I'm not 100% confident, they're dead anyway, so
dead.
I should
What
try and
you
give
need
them
to
a
do
chance.
in an arrest, the patient is dead. You do what it takes. If they've got low potassium, are you going to hang up a bag of 40 millimoles of potassium? You're going to bang it. You can't guarantee it will work, but it's the best you can do.
Do you get somebody to hold the ultrasound for you while you try and
You
get
can.
a needle, or do you just do the old fashioned?
I think
with
for
the,
me, I would probably go for the old-fashioned landmarks.
yeah.
I wouldn't
Fair
find.
enough.
The problem with ultrasound is, even with the ultrasound guy,
Yeah, it's
doing,
hard.
it is. So for ABGs, when they say ABG, I don't know how to do this guy. Sorry, I'm old. Yeah. What was I saying again?
So
Sorry.
you said even with ABGs?
Even with ABGs, right, they say ultrasound guided ABG. How are you going to do an ultrasound? Sorry, we're doing the rush. So, it is for identification of where the artery is. You're not going to go and hold it and the patient goes, ow.
Yeah, no chance to do something.
Okay, questions? Everyone okay with the ELS? It's simple. It's don't worry about it. At your stage, I don't think anyone would ask you to do it anyway. But feel free to do it if you have the chance. If you're in A&E. So remember, we said, I don't know, some of you I was talking to you. So what was his name? Paul Atkinson. That's him. So he was an English guy, worked in Cambridge, came up with this: the abdominal and cardiac evaluation with sonography in shock. And he called it ACEs. And then there was this lovely man across the pond called Scott Weingart, and he came up with that. The rapid ultrasound for shock and hypertension. Essentially, they're the same. Essentially. The idea and the thought process, you will see. And I think those of you who've worked with me have already kind of clued up. So that's POCUS, or point of care. So you've got a 30-year-old male, RTC, 40 miles an hour, collision with a tree, airbags deployed, no death in the compartment, self-extricated, but was found lying on the road. Okay? Blood pressure slightly tacky, 110. Heart rate slightly high, blood pressure slightly low. As you can see, completely unequivocal. Sorry, not to help you. No obvious head injury or neck injury, no obvious injuries apart from the fractured wrist. What are you going to do? Wrong. Wrong. He's just arrived. What are you going to do, Doc? Come on.
ABCD.
Yeah, you do an ABCD. You call the trauma team. If you don't have a trauma team, you do ABCD. You look at it, make sure his air is breathing, is that. Things change. Things change. You keep reassessing. And that's a bit of emergency medicine. I know where this is ultrasound. And so, remember what we said? The EFAST. We did EFAST, right? So Hugo went through this. So now you guys are going to tell me what these are. I'm going to point, you're going to tell me which one. Can't hear you. Brilliant. The food, Raza, Michael had a full voice. What's this? Excellent. What's parasternal? Which one? No. Parasternal. It is L, but what is it? Long axis. It's long. Excellent. What's this? Suprapupil. They've done it like this, and that's just to see, gives you better images, and sometimes you can quantify it. But essentially, it's the same what we were doing. Okay. What's this? Yeah, that's what we're looking at. What's it? Left upper quadrant, right?
Yeah.
Brilliant. And what's this?
Subxiphoid.
Yeah, subxiphoid. I can't remember what you were saying. What's this? So this is the fast scan. This is extended fast. So what have we done? What's the difference?
Just added a pneumothorax.
Which one?
3.
3. Brilliant. Yeah. So essentially they're all the same, except they don't have the parasternal. So you can have either or. Okay? So 1, 2, 3, 4, and you've got 5. Here would be 1, 2, 3, 4. Forget the one on the parasternal. Okay, so the right upper quadrant, you see this. What are we looking at? What are we looking at?
Like freezing on the top of the kidney.
Excellent. Yeah, right there. Right?
Yeah.
It's not. Apparently that's not.
That's fine.
So I thought that one, that's why I kept it in. But allegedly, the people who labelled it, they said this was a normal scan. But I beg to differ. But anyway, so that was a trick one. But, now do you see the fluid? Okay, so it's quite obvious now. And there we said, this is the diaphragm that we were looking at, this is the right kidney, and there's the liver, and there's the fluid there. Left upper quadrant, what are we looking at? Someone help me, what's this? Yeah, this is the diaphragm, what's this? You can read, brilliant. This one, brilliant.
Left upper quadrant.
Yeah,
To the left.
and this is the inferior, and this is superior because we're holding it like this, if you remember. What's this? It's a super big, yes, exactly, it's a TV. And that's what we, for those of you that were working with, we use the bladder as a window as well. Good. And what's this? You can read. So this is the longitudinal. Remember we showed you two. So if I was to go, this is what it looks like, the way we were doing it, transverse. Okay, and any free fluid would be here. And this is when we do it transverse, and in a male, you will see a prostate. In a female, you get the uterus. And this is a positive transverse. And this is the subcostal, again, normal. So you guys should be quite good now with this. So it's left atrium, left ventricle, right atrium, right ventricle, and we're using the liver as the window. What's this?
It's fluid around the heart.
Yeah, so can you see that? If he's flat, you're welcome to put a needle. If he's not, no. Okay. Unless it's imminently, he's arrested, in which case. So far we've gone through, I've given you examples of every probe, okay? That was fast. That was the fast part of the evening. This is what's this? It's a pneumothorax. And if you scan it, remember what Hugo was telling you? So what are the,
The
anyway.
hair sign.
It's not gonna
Go on,
slide.
tell me the sign. So I'm gonna point and you tell me, what's this?
The fluid's not gonna slide.
Yes.
So
So you won't have the sliding or the
Yeah.
shimmering or the ant, okay? And what else, or what do you have? Can you see?
The
it's
So
a
V lines.
barcoding.
So yes, you would get barcoding. When will we get barcoding?
Then it's like a pneumothorax, barcoding pneumothorax.
How would I get that?
On the M setting.
On the,
Is it M setting?
on the M setting. So you wouldn't, this is a normal setting, we're just doing it like that, transthoracic. So in order to get that, I need to get the M setting, and then it will give me barcode or beach. But in this case, you can see the rib, so the hypoechoic, rib, hypoechoic. Let me show it on that one. Rib, hypoechoic, rib, hypoechoic, and then we're going to say that's the bat, so to speak. That's the lung point. What is the lung point? Does anyone remember? We did say we're going to
The area
test
between the
it.
two pleura,
Sorry?
the area between two pleura, the outer and the inner one.
That's not the most likely point where the air will rise and you have more likely to.
So remember what we said, there was no movement.
Yeah.
Okay, so lung point where there is start, there is a. Hugo, would you like to tell us more? Go on. We've all forgotten it.
Ooh, long point.
So you have 10 seconds.
Remember, long point. It's a
Yeah?
point where there is between lung
Yeah.
and air. It's meaning pneumothorax
So
and
pneumothorax,
lung,
remember? Right.
right? So it's just the point where you're gonna find
We're
an
not getting it, we're not
an
getting that shimmering.
inflated
but then
lung
you get the neck,
and the
it goes all
pneumothorax.
the way there.
So in one part will be the seashore and the other one will be the
Who's
barcode.
going on the sun
Both
side
together.
next? Sun side.
Is the
You can see it
point
on the
when
sun
they
side.
connect.
Very better.
Is that clear?
No, we lost them, it's the food. They're going. Before we move on, they need to dance. Okay, so there's your barcode that we were saying. So you can see it's barcode. Personally, when I first got told that this was barcode, I saw both of them as barcode. Would you do you agree?
Yeah.
I was like, who came up with that? Oh gosh, you could have barcode and barcode. It's just a different barcode. But then I was told to imagine that this is sand. And then you imagine that these are ocean waves. And then you have the sky. Anyone awake?
Yeah.
Okay. So apparently
it's-
this is a larger chunk, and
It's
quite-
obvious, you see the people there playing on the seashore. Look,
No, those are
Yeah,
common
look.
sea lions, those. If you don't understand the lung, don't worry, it is a pain in the beak. Yeah, it is. And this is just the algorithm, I just put it in there in case. So if there is lung sliding, there is no pneumothorax. If there isn't, then we look for the B lines. If there are B lines, then there's no pneumothorax. If there aren't, we look for the lung point. Okay, so we see whether there is anything beyond the black. And if there is a lung point, then there is pneumothorax. If you're not sure, you do more. Do a chest X-ray. Okay, so this is the ACE protocol. Just put it in there for comparison. So ACE have said 3 cardiac views. 1, 2, 3. What's this? What's number 2?
That's supposed
Nope. So number 1, that's the subxiphoid. That is the parasternal short axis, and this is the apical forechamber.
Is it the one where you go past the liver?
So this is the past the liver. So you go in like this and you
Yeah.
swoop. So that's the subxiphoid. That is the parasternal lung, but he's then gone like that.
Okay.
So it's short. And then this is the apical forechamber. Okay? This is IVC.
Okay.
What's this?
Yeah.
Got me worried there. What's this?
Left upper.
Left upper quadrant.
Right upper quadrant.
6. So there's 6. Okay? So I'm going to speed up now. So they came up with this. I'm not going to go into it. But basically they've managed to then break it down for you. So you've got the rush, that protocol. Sorry, there you go. It's probably better to take a picture of that one. And then you divide it into, and they've said, oh, if it's obstructive pulmonary embolism, you'd find this. And if it's obstructive cardiac tamponade, you get that. So they've kind of done the hard work for you in that. This is the rush. So let's go through the rush protocol points. What's 1?
Is subcostal.
Yeah, so it's subxiphoid. It's the one. Yeah, or subcostal. What's 2?
It's apical.
You can read it over there. I was going to say I can't stand here. Okay. What's 2? It's the apical forechamber. Okay. And then we've got 3. Excellent. 7. Aorta. They show you the. Remember we said 3 pictures. Number 6. 4.
Right upper quadrant.
5.
Suprarenal.
Left upper quadrant. Which suprarenal?
Suprarenal.
Spinal. Yes. So you were saying. Sorry, I thought you said suprarenal. No. Okay. And what's 8 and 9?
Just the 2.
Yeah. So they've come up with 9. So they've left a few of the cardiac out. And the idea behind it, in a nutshell, the IVC, if it's compressible, the tank is empty, give them fluid. If it's not compressible, don't give them fluid. The hypertension, look for another cause. The echo, you're looking at the echo, you want to see whether there's a right ventricular strain, i.e. the right ventricle is full, then don't give it fluids. If the left ventricle is collapsed, give the fluid. Did you see how they thought? This is how they came about. And then you've got the flanks, and the rest of the fast is just to look for free fluid in the abdomen, in which case you would support that with hypovolemia. So in summary, told you it would be quick, because it's basically fast, and that's why we gave you time with the fast. If you got fast, the rest are just a combination of everything above. Fast, extended fast is just the one with the lung, AAA in the center, IVC to the right, feel, fake, CASA, FICE, these are the echocardiography protocols. ACE, rush, and shock are all the shock protocols where they incorporate all of the above. Okay, and then the ultrasound the lungs is the blue protocol. Sorry, is there anything else? And others. There are many others. You'll come across them as well. Any questions? So as I said, it's really with the life support and with the rush, it's all geared to identify causes that are correctable and to expedite care so that you don't drown someone who is of flooding in his fluids, and you don't deprive someone who is dry from fluid. Okay. Yeah, sorry, someone you might
So
keep
the rush is basically when to give fluid or
Yeah, so basically you're thinking of pump failure versus tank failure versus, there was something else, pipe failure, okay? So IVC and aorta, yeah, so, yeah. So IVC is the tank,
Yeah.
lungs are also kind of tank, kind of. The pump is the heart, and pipe. Aorta is the pipe.
When you said if you could compress the IBC, but could you not theoretically compress it if you put enough pressure on it?
Well, it's usually.
If the right artery, yeah, of course it will, but
Yeah.
there's a criteria if I remember correctly.
Okay.
I think it's 1.5. If it's 1.5 and compressible to
Okay,
0,
Right.
that is empty.
Fair
If
enough.
it's over 3
Yeah.
and you can't get it down beyond
okay,
that,
okay, yeah.
then that is.
Fair enough.
Yeah. If I were to add, yeah, sometimes if the patient is really dry
Yeah.
and he bled a lot, definitely we call it kissing. So you'll find that the vessel is almost collapsed. But if you can, if the vessel on the longitudinal section
Yeah.
is that big,
Yeah.
is big,
Yeah.
and you don't need to measure it sometimes. Measuring it will give you this variation when you give, for example, a bolus of fluid and
Yeah.
you want to check if
And you
there is
can do
volume
it,
or
you
not.
can
But
fix it.
if you have a vessel that's that big in the longitudinal and it's not even changing with the breathing,
Yeah.
it means that
It's not.
it is not, and there is a pressure
Yeah.
in the heart
Right.
causing this issue.
Fair enough. That
Call
makes
it
sense. Yeah.
a pericardial effusion, call it whatever.
Fair enough. That makes sense.
So it's just to tell you about the status.
Yeah. Just remember the IVC, you can only use it if the patient is not ventilated. If they're ventilated, there's an increased intrathoracic pressure.
exactly.
That's a whole different conundrum. Okay, so if they're ventilated, you can't.
Yeah, that makes sense.
As far as you're concerned,
Yes.
other people do maths.
Yeah.
They can work it. Like that.
All right. Good. All right, it's me again.
I think you need to make them stand up. Honestly,
Mine
stand
is
up,
short.
turn around, and sit
Mine,
down
mine
again.
is short and sweet so that we can get more hands-on on the practice. I know that some of you did not grasp 100% the EFAST, so we'll join everything together, the EFAST, the rush protocol, whoever missed anything, then we can catch up with the practice. Is that all right? So we're going to talk about the vascular access and the fascia iliaca block. So the vascular access is the skill that each and one of you need to master if you're in A&E or any other specialty. And it's really, really, really important. So, what we use it for, central lines, obviously, using the ultrasound to get the vascular access in central line, it's kind of becoming now the standard of care. Some people who are really talented going with the landmarks, it's fine, but at the moment, all the Royal Colleges recommend using the ultrasound. Peripheral lines, when they are difficult, you have an IVDU patient, you can't get an IV line, then that's the way to go if you manage. And obviously, with the arc line, again, similar to the central line, we're using that. Some people use it for the ABG, all right? But ABG is it's not something that's difficult, but if you want to really reduce the chances that you can get it wrong, so you can just use your ultrasound. What you're going to need, obviously, is the linear probe. We agreed that with the high frequency, it will give you good resolution, and it's a shallow anyway. You need the cannula, you need equipment, all the equipment needed. You need a probe cover, ideally, and the gel sachets. Gel sachets. So you're dealing with IV access. So just make sure that the field needs to be clean. And obviously, if you're going with a central line, there is the all the precautions. So your gown, your sterile gloves, you need to do them in, and obviously you need to make sure that the probe is really covered. And this is a totally different kind of session for each. All right, so remember what Hugo said about the approach. This is very important. The last thing you want to do is to go putting a line, and after you tried the pink one, no, it's not working. You go back again and get the blue one, and it's not working. The majority of you being there, so preparation is a key. Everything needs to be there. And again, you need to be comfortable. You deem that as a difficult airway anyway. Get a chair, sit next to the patient and try to do it. And don't forget that you are dealing with a human being. Just be very, very gentle with this patient. Address the things that, and the rest of the things that Hugo said on his session. All right, where is this part, do you think? In the human body. Where is that part?
Neck. Neck. And the neck.
Which part?
The foot.
Yeah, yes, exactly. Cubital fossa. All right, so these are the main things. This is where we go. Well, yeah. If you go down there, you can use the ultrasound, but you don't get much there. You need to go for the juicy part. Okay. Who's usually use who use access? Yeah. All right. Have you tried the Basilic before?
Yeah, I actually find higher up can be sometimes a bit easier.
Easier because it's bigger.
Yeah, yeah. And if you get the long cannons.
The long
well,
cannons.
yeah.
And this is the trick. Unfortunately, on this demo that we're going to use, we have a small needle. We have a small canyon. Definitely, you need to have a long one. Okay. So this is something that you keep in mind because the majority of the blues, if you try for a deep vein, they're gonna tissue after some time, and you will lose all this nice job that you have done. All right. So obviously cross section. Find something that looks like a vein, anechoic. You press it. See if it's that vein. Make sure that it's not an artery. Artery usually be versatile. You can throw a Doppler into it and go with the needle. If you want to put it longitudinally, you're gonna see the needle going in. And this is a video, a short clip. So press it. This is a vein. And as you go in with your needle, let me freeze that. See, when you find the vein that you are going to attack, just try to put it in the center of your image. And you can also reduce the depth. The vein will be up there, and the rest of the page is, or the image is empty. So just decrease the depth, make it big, make it easy for yourself. All right. Yeah. This is the cross-sectional view. You are in now. You can see the needle is in. And when you turn the probe 90 degrees, you will see the longitudinal view. All right. This is the vascular access. Nothing much about it, to be honest. It's just you need to keep things clean. ANTT approach. Okay. Any questions about the vascular? So we're going to practice lots of vascular access. All right. Facial iliac block, FIP. Sorry, half of it is away. Who's doing FIP among the? You've done it before.
Yeah, usually landmark though, I don't.
Landmark. Yes.
Yeah.
So you can the facial iliac block. First of all,
Neck of femur fracture here.
neck of femur fracture is the commonest one. Yeah.
No, they don't accept them.
No, they don't. You're right.
Yeah. So this type of block it is a skill that emergency medicine should have. Orthopedics also, anesthetists are already having this under their in their toolkits. Now this is the standard of care in managing neck of femur fracture.
If you want to be a favorite doctor of your nurses, you need to have this. Otherwise, they will piss you off.
Yes. Yeah,
You
exactly.
can't work in the A&E without this.
So,
There's another issue though, they want this done within 2 minutes.
Yeah.
So it's like, wait a minute, you need to move on to all the other things. Or do you want me to spend half an hour doing this?
yeah, so they want it fast because usually these patients are fast tracked through A&E.
Yeah.
You detect it, you keep them analgized by giving the facial yaka block, fluids, bloods, and send them to the orthopedics.
Send them to the medics because they've got UTI.
By the way, this is quite extensive.
That's true.
Extensive topic, so
Yeah.
we have a half-day course for this.
Exactly. So that's why I'm going to rush through it. I'm not going to focus in this. I'm just going to give you broad line. To master these skills or to start mastering it, you need to have a course dedicated for fish. So far, we don't have the facial yaka models here. All right. So now going further, the indications we talked about the fascia for the neck of femur. One of them again, fractures of the femur. You still can't technically give them the facial yaka block. In a nutshell, it's you going to deliver a block, an aesthetic regional block with a high volume into a compartment and hoping that in that compartment you are going to anesthetize or knock the femoral and the lateral cutaneous on part of the operator. So technically it's mainly the femoral plane. Okay? And this will give you numbness and anesthesia for the entire thigh area, and it's really great. Patients will really feel better if you get it right. Okay. So these are the indications. What is it? We talked about contraindications. Anybody knows about contraindications? Any real contraindications?
Can't think of
Yeah, it's not like contraindications, but if you have someone with a distorted anatomy on that area, yeah, you won't be going. Again, patients who are all over the place, elderly ones, they are not cooperative. They are going to, harm themselves, and you can sustain an injury. So there is, I would say, precautions. So patients who are on warfarin and patients who are on anticoagulants, just make sure that you be very extra cautious with them. What are the complications? Infection, obviously, the first one. Hitting hematoma, yeah. If you hit an artery or a vein, you just press on top of it. And obviously, using the ultrasound, the reason why you're here is to make it more safer, not avoiding hitting a nerve or an artery or a vein.
Can I add something about thinking about contraindication also? Remember, it's not contraindication, but if you're gonna do a bilateral neck of femoral nerve block or fascial block, that is something that you will need to think about. It's very rare to have a bilateral neck of femur fracture, but the trick here will be the same dose, the total dose for divided half and half, right? So the other contraindication will be if you had actually a nerve injury there. What happens if they dissection a nerve? There is no point to block that nerve because there is no sensation there. Or a previous history of a cellulitis, infection around it, an abscess around it, or a previous history of bypass or vascular surgery on that region can be the main problem.
I think maybe a
doing
lymph
ultrasound will be the safest way to do it.
lymph node clearance may be one of the contraindication. If the patient had some
Distorted anatomy can be
Yeah.
a relative one. But obviously the medication that you are going to use here, guys, it's not like lidocaine, it's bupropion. Because of the duration of action, so you deliver it and it can give you 4 hours, around 4 hours, pain-free if you get it right. What is needed? The same thing. Go. All right. So preparation is important. Get the ultrasound. Get everything ready.
Spinal needle.
Exactly. And one of the things which is important really on this approach when it comes to the facial yaka block is the documentation, guys. All right. You need to document. You need to document the vital signs before and after the procedure, because we know also one of the complications that if you accidentally inject this anesthetics inside a vein or an artery, this can cause toxicity. Okay, which can kill the patient.
Can I add something? Is after you finish to do it, right? So you need to have, the patient need to have at least 30 minutes of observation before being moved on to the ward. So you will need to explain the nurses to do, I think it's 5 minutes, then a 10 minutes, then a 20 minutes. I normally do is just do every 10 minutes for 30 minutes. And if the observation finds the patient can be moved on and document that.
What is exactly are we looking for observations?
That's important. Why? Because you are using a local anesthetic, that's bupivacaine, so you're looking for side effects. What you don't want is that this patient be moved on just straight away of putting the local anesthetic there and goes there and have and getting shock and die.
Yeah.
Because that's the main problem, local anesthetic toxicity. Those patients goes in shock.
Oh, okay. So
Right,
looking for
so
hypotension and
hypotension and arrhythmia, and then they die. So it's important, guys. This is very important part. Don't just be very firm that observation for 30 minutes. I normally say every 10 minutes for 30 minutes. Don't move the patient before that, because there were cases that they went upstairs and actually they have an incident.
Don't forget the compression as well.
So yeah, they can develop the arrhythmias, and you can go through you need to know what signs to look for these kind of local anesthetics. Thing. Yeah. So,
What's the antidote for the brilliant? Who said it?
intralipid.
Well done. Where do we keep the intralipid?
We need to know.
Exactly. You need to know where the intralipid is in your department. It's usually in recess, but this is a very important drug.
It's very
Yeah.
expensive. So
Yeah.
some hospitals they just keep it in the theaters where.
I thought that was pray.
No?
It wasn't pray? I was pray?
Oh, pray. You do that
So
too.
you just pray that you can get the intralipid.
Often in ED, so
You-
one of the nurses will have the key, so you can't go and get it.
It is very important drug to know.
Yeah, you need a thumbprint.
First with the key.
If you've got the machine that they store everything, they need a
Because they
thumb.
feel that there's a different
Okay.
diagnosis.
Okay, Mike, you told me that you do it with the anatomical.
Yeah.
Can you tell me how you do it?
Well, we were always at med school taught Navy, so you just palpate your landmarks, but also halfway between the pubic symphysis and the anterior superior iliac spine. You go halfway and then a centimetre laterally is a safe area there.
Same area.
Because I think you're given such big volumes that you don't actually need to be right on the nerve. It's more of it almost has a bit of a tamponade around the nerve, I think, as well. But and you feel a kind of pop as you go through.
Yeah.
But yeah. And
How many pop? How many pops?
Not every time, but you're supposed to. But yeah, no, it's just that our departments now are saying you have to use ultrasound to do it, but yeah, it's been doing it for years without. So
Agree. Now, I think still in my trust, the orthopedic taught or the anaesthetists teach the orthopedic doctors to do it with the 2 pop techniques or 3 pop techniques.
Wow, your orthopedic doctors have learned it.
No, yeah,
Well,
some of
they
them.
learn, but actually as
They send patients back to A&E to do
to get
it.
it done.
Yeah.
Okay, let us all agree that with the Royal College of Emergency, they are recommendations also.
Yeah.
Yep.
Exactly. So this is a bit of anatomy, and what you need to do is with the needle get to this area here where you can inject your local anesthetics, and it will create a very nice expansion of fluid. So there will be separation of the layers on that area, the yellow area, where you're going to where your fluids are going to sit nicely, and it's going to surround your nerves, and you'll get the anesthesia that you want. With ultrasound, obviously, you won't be anywhere near the structures that you don't want to be near, which is the artery and the vein.
do you remember, any one of you remember the mnemonic of that?
Yeah, Navy, isn't it?
Navy,
Yeah.
yes.
Also when we
I go for van, doesn't it?
Oh, for van.
Yeah.
Van,
Uh-huh.
yeah.
vein arterial.
So can you see that? That's a bit close.
Yeah, that's a bit too close.
That's a bit too close, but seemingly someone who is
No, he
really
retracted,
expert.
he retracted, that's okay, he didn't
Yeah.
inject,
You
or
need
maybe
to
he's crazy, I don't know.
No, it's
Yeah.
getting closer there.
Using the ultrasound, obviously, you need to keep an eye on the tip of your needle.
Yeah.
Alright, and again, when you are injecting before injecting, you need to aspirate.
Yeah.
Aspirate. So inject and aspirate. You don't need to push it all, pack it all, all at once. So you can put in, aspirate 5, aspirate, nothing's coming, give it. Can you do it alone?
Yeah.
You can't. Technically, you cannot. You cannot. You need someone because you'll be holding. Usually, we use the needle, the spinal
Yeah,
needle.
I do it, Lord.
Well, you are an expert. I will ask someone to push this fluid so that he can do the aspiration and push as well when if there is a thing coming out. So it is an important procedure for the neck of femur. It's a standard of care. People who are wishing to pursue in emergency medicine training, they need to master this as soon as. Okay? And it, again, like any other skills, practice till you master it. Okay? I think this is the last slide. Now, faculty, anything to add on this? Husam, Hugo, Bashar?
Sorry, what was that?
No,
You want to add anything to this?
Os-
No.
Osama, just a question, because I could see that there are quite a few who are in the post-plan candidates.
Yes.
Now, keeping the job situation into mind, what do you think, what would you say about those skills that they acquired today are important or not from the interview point of view?
Yeah,
In any?
well, anything counts. So being in this course is good because that will give you a certificate showing that you are willing to for the training and go further. Obviously, this
Invest
course
in your
is a start.
development.
These skills are not really. If I am to hire someone and he's having these skills in his toolkits, I'll be definitely excited and I will hire him.
Yeah.
But
So-
it is not. It depends on what you are applying for. If you are applying for a junior level clinical fellow kind of thing, don't expect them to know how to do it well. If it's a registrar working somewhere for quite some time, we expect them at least to know how to do central line, how to do fast card and AAA. Those are the basic ones. Patient Jakob Lok, maybe. Husam?
So what I would say is, for those of you who have just joined, the juniors who are looking for clinical fellow SHO post, this would definitely be classified as a desirable. It's not a needed. It's just like ATLS, APLS and that. So it's good to have on your CV, okay, because you're stacking up, isn't it? You're showing that you're invested in your personal development and you're making that up. So it is a desirable. When you're looking at when you're applying for a job, look at the person specifications. It will show you what is mandatory and what is desirable. And in your category, this would definitely be a desirable. So it means that it puts you ahead than a few other candidates. Okay. For the regs, I think you're on it's
Yeah.
And that's
mandatory.
mandatory.
Especially,
You're knocking
especially
on the
now with the
mandatory.
job climate,
Yeah.
it's really
Because the fascia block probably more important than anything else, and probably the fast scan, but we don't use it as much. So it is the FIB block that you have to have under you, as Radha was saying. The nurses won't leave you alone. From the fast point of view, we don't usually use it anymore. So it's now found its way into the rush protocol. So we use it more
Now
for medical
again,
cases.
we don't run the trauma centers everywhere.
yeah.
No, but remember that it's not much a fast protocol, but it's
It's the
FAF.
skill.
But
Yeah.
it's the FAF
Yeah,
now.
It's the FAF, yeah.
It's the FAF,
Yeah.
focus assessment of free fluids.
Yeah.
It's just looking for free fluid in a non-traumatic patients. And especially also that the medical patient that comes with ascites, that can give you a hand, can be a help.
I think these are very essential skills, even if they are not trauma.
Yeah.
I
mean-
can remember a case that we did together, the pericardial
Pericardial
fusion. It was a nightmare. I saw the first time, and fortunately, I met Osama. and he did the scan. And that lady survived, but she ended up having a cardiac arrest, bypass, and
Yeah,
So
so
it is.
these skills are.
I couldn't really imagine 2 days history, just cough, cold, fever.
I think what you really need to remember about this is that it's the hand-eye coordination. Forget the protocols. It is getting that skill. If you have that skill, you've opened a whole new, side to your practice. Whether it's acute medicine, GP practice, what do they call it? Wilderness medicine. In mountain medicine. These are all spots that you can now. You don't need a CT to image. You can get them back. You can diagnose fractures. You can give injections into joints. You can joint diffusion. You can do so much. And it's a skill that you will take with you. You will never forget it. As soon as someone hands you a probe, you'll find that once you've got it, you've got it.
You can actually do ocular ultrasound. You can do testicular ultrasound. That's very advanced on level 2. And DVT, for example, is a quick, a very important also test. Yes, I think today is just more the basics and the fundamentals and of the ultrasound, and just try to make it easy for you and understandable about these sort of skills that will need some further probably improvement and more advanced courses for those.
Yeah, and the evidence are showing that these skills are easy to learn, and once you learn them and master them, you usually yield a high level of accuracy in terms of answering those specific questions. Talking about skills like the pneumothorax, things like the free fluids, hypernephrosis, things like even looking for small bowel obstruction or ischemia in kids, what is it in kids? Interception, yeah. So interception. So there are plenty of fields where now ultrasound are becoming really helpful and almost the gold standard. Almost, not yet.
Renal, for example, renal colic, just to say hydronephrosis.
Good. So we finished the theory. I want to give you more time for practice. We're going to start with the coffee. That will give us time to calibrate things here. Do you have any questions about the theory, guys? Thank you very much. Any?
Yeah, getting tired, so I think you need a coffee. Coffee time.
All right.
Move legs. I think it's coffee time. Yes. Just get ready for the practice.
Each you one in one. They are applying for a job.
Virtual models.
Yeah, definitely. Now the clinical attachment is difficult. I think that was taking 5 years ago, patients who got a premature discharge that we as a consultant will take more time to review.
They have a kit called Doppler.
Very important.
And for the manager, that was easy action. No more attachments, unfortunately. We are trying to change that because myself, many of my colleagues,
Forget. Modify, enjoy.
I can ask.
So 2-3 days we keep them on radar and then we discharge. So my idea is the people come from overseas.
As I explained to them, we don't have.
I just generated an idea now. So the one has already GMC and they're seeking job and living in this country doing this. Why can't we engage them in a virtual team, virtual body?
And
As a
yes,
volunteer,
just
to start off.
I had also,
You know what I
I
mean?
think, thankfully I'm not a CD, but I don't know.
similar case, and I went through.
The volunteers can't be held accountable.
No, I told
Maybe
you.
like an attachee,
Yeah,
but
they're not
they
accountable, they're
know.
not allowed to do work, they're observing.
And I remember I started
They have to be paid, they have to be paid.
Yeah,
Because we don't
otherwise
pay
they'll not be
There is a
accountable.
scheme for refugee doctors. We have
They are being paid, they are being
they are being
paid.
paid.
That's why they're
Their
accountable.
ranks are very low.
In Southport, I think
But then
just
they get paid.
the queue is
Yeah.
long.
I'm just thinking, and I don't
In
know.
MRI,
have
they
actual body
don't
knowledge.
being paid. Yeah.
Virtual and unit skill ranges, you doctor.
Yeah.
A small incentive they can start.
If you give them something, yeah.
Not me who is going to give them.
Hospital, obviously, hospital.
One up to
And
the
see,
think tanks.
Yeah.
The one has finance. रोना ये है कि रो रहे हैं.
I've got three training,
they don't have to pay for the house.
but maybe in the future.
Fraction of cost and they will get some.
They should have a formal program, you just email the Coast
वो ये
Guard
कि फिर ये
Department.
लोग जो teams है वो community में
Royal Albert
community
Edward
की help
Infirmary, and we can, out in the middle of nowhere.
जब तक इन्हें regular job है.
No, I think we're closer to.
The ladies don't like
Yeah.
coffee or what?
So they're naughty, so instead of they normally.
What about that group there? No coffee? No coffee here, no coffee
Now they
here?
give you one.
No coffee, guys?
They tell you-
No co- are you sure? Come on, guys.
I can say yes, I can say yes, but I've done two already, so I think it's August and July.
Maradona? Oh, well. So far, he's getting his views going through. Come on, guys. I think your email a little bit of energy makes you more awake.
You put my email on the website?
Oh, yeah.